From the JAMA Network, this is the JAMA Pediatrics Editor's Summary, a discussion of the most important articles published in the latest issue of JAMA Pediatrics.
Hello again, podcast listeners. This is Dimitri, Christakis, Editor-in-Chief of JAMA Pediatrics, joined as always by my friend and colleague and Associate Editor, Dr. Alison Galbraith from Boston Medical Center. We have two interesting papers again this week. As always, Allie, you want to start us?
Yeah, this paper I like a lot because it's about an area that I study. It's about out-of-pocket spending for non-birth-related hospitalizations of privately insured U.S. children, 2017 to 2019. It's a study from Carlton and colleagues at the University of Michigan. They used IBM Market Scan claims, which are a national database. It contains millions of people with employer coverage. And they did a cross-sectional study where they estimated out-of-pocket spending for hospitalizations among privately insured children, and then looked at what were the associated factors with that spending. So they looked at hospitalizations in that time frame from 2017 to 2019. They looked at children aged 18 or younger and excluded anything birth-related. And then for a subset of patients, they had data on benefit design for their insurance, and they looked at those who had plans with deductibles and with coinsurance. And so they wanted to see how the out-of-pocket spending varied by the deductible level and coinsurance level. And so their primary outcome was out-of-pocket spending, which is how much was spent either as a sum of the deductible or a copayment or of coinsurance.
And Allie, just to set a little broader context for the audience so they understand, most of the patients we take care of course, in children's hospitals anyway, are Medicaid covered, and they typically don't have any cost share, any deductible, right?
Little to none, correct.
So this study, Allie, looks at a different population, a privately insured population, which we normally think of as having the benefit of insurance, which is a good thing to have in general, but it comes at times with out-of-pocket expenses. Is that right? Did I get this straight?
Correct. Yeah. And in this particular respect, kids with Medicaid are protected. They have really very little to no cost sharing, and families that have employer coverage, especially if you're like the child of a low-wage worker parent, these costs could be substantial. And so they did find that hospitalizations were costly. So they had over 183,000 hospitalizations. They found that the mean out-of-pocket spending per hospitalization was a little over $1,300. The median was like $656. And they found that 14% of hospitalizations incurred out-of-pocket spending that was more than $3,000. So that's a big hit all at once.
They're all big hits.
For sure. They had data in some secondary analyses about benefit design, so they could tell who had plans and how high the deductible was and what the coinsurance rates were. And so if you had a higher deductible, you were more likely to have higher out-of-pocket spending for your hospitalization. Or if you had higher coinsurance level, you had higher out-of-pocket spending. That's not surprising. But there were two other factors that were interesting, one of which was that they found that if you were hospitalized in the first quarter of the year, you were more likely to have higher out-of-pocket spending than in a later quarter. And that they attributed to the fact that, people's deductibles usually reset in the beginning of the year. And so they're at risk to pay the full amount in the beginning of the year. And maybe by quarter four, they've exceeded it and they don't have to spend as much. The other thing they found that was sort of interesting was that higher out-of-pocket costs were associated with not having a chronic condition compared to having a chronic condition. And the way they talked about this was that children who have chronic conditions are likely to have other out-of-pocket spending, say, for example, for medications or for outpatient visits. And so by the time they have a hospitalization, they may have exceeded their deductible and they may have lower out-of-pocket costs per hospitalization. And they did some exploratory analyses looking at other out-of-pocket costs besides the hospitalization that kind of confirmed that idea. So those are the main findings.
Well, no, I think it's interesting, because, and you're probably about to say this, but, medical bankruptcy is one of the most common reasons that families go into bankruptcy. It's from medical debt. And we normally think of this, of course, for adults, but children are part of the equation too. These costs, $600 to $3,000, if you're a low-income working family with private insurance, is a sizable amount of your family's budget. And
And part of the problem is if you have a hospitalization that you're not expecting, like you're generally have a healthy kid, but something bad suddenly happens, then you're on the hook for a big chunk of change that you weren't expecting. And so that, I think, is where people might have trouble, they get sent to collections because they can't pay a big bill all at once.
Well, that's right. And of course, it's not uncommon when children are hospitalized that parents also miss a lot of work. And depending on the length of their hospitalization, may even lose employment. So there's a double hit.
Hmm.
And you said something else that's interesting about collections because, most of us, or many of us, I shouldn't say most of us, probably actually few of us, work at children's hospitals that have uncompensated care budgets. But that's certainly not true of all families. And many places probably do send bills to collection and stress families out.
Yes, and those uncompensated care programs, people aren't always aware of them, that they can take advantage of those.
One of the challenges when I think about this is that, there's been a lot of hype. I'm sure you're aware of this, like transparency and pricing, which has been a challenge to actually do. I mean, as a clinician, we often make decisions without any attention to costs historically, which has been a problem. But even if we know the cost, we don't know the cost to families. And, that data at the bedside, whether or not it should have informed clinical decision making, is lacking. In other words, if you're on the fence about getting a CT or an MRI and you realize, well, this is going to cost this family $200 or $500, would you order differently, Allie? I guess I'll ask you because you're a real doctor.
Well, but the thing is, I think, this idea of consumer-driven healthcare and shopping for your care, it does maybe work when you have an MRI that's not very urgent. But if your kid is, acutely ill in the hospital, you can't really go around and shop. Plus, where else are you going to shop to if you need highly specialized care at a children's hospital that's really pricey? Or, you can't control where there's a bed available like there was over the winter. So hospitalizations don't really fit that well into this idea of people being consumers.
Right. And I guess one argument would be we should just always be mindful of costs because they will impact our families. Of course, the truth is probably little that we do in a hospital stay is going to affect this bottom line, given that they're probably going to hit their deductibles anyway. But I guess it's good to be mindful.
Hmm. Well, one other thing that I think when we talked about this paper initially, one of the things they found was having a longer length of stay or being in the ICU was not that much more costly. The spending wasn't that much more than if you were just there for like a day or two. And, you think of these soft admits that we have sometimes where you're a little bit on the fence about admitting a kid or not. That could be, the cost could be really burdensome to the family. And is that something we should be talking about with families? Like if we're trying to decide in a case that could go either way, should we be talking to the family about, are there other alternatives that aren't going to cost you as much?
Excellent point. And the next paper we have is the effectiveness of structured care coordination for children with medical complexity. This actually segues nicely from the previous paper. So I think as most of us know, the complex care children that we care for are a relatively small but very costly segment of our populations. And one of the challenges with them is coordinating their complex care. And for many years, there's been this belief that better care coordination would result in better outcomes for these children and their families and lower cost by obviated ED visits and hospitalizations. So this group from Ontario did a randomized controlled trial using a waitlist design to test whether or not coordinated care model impacts outcomes. And I mentioned it was a waitlist control model. So they identified kids that were eligible, and we'll talk about the eligibility criteria in a second because I think they're important. And they randomized them to the intervention, which basically was a nurse practitioner partnered with a pediatrician to spend time coordinating the care of the children, tracking down medical records, looking for appointments, et cetera, compared to usual care. And the usual care waitlist control was a 1-year waitlist. So they basically looked at outcomes at 12 months and 24 months using that randomized approach. They looked at several outcomes, and I think the primary outcomes were 3 domains. The first was coordination of care among healthcare professionals. The second was coordination of care between healthcare professionals and families. And the third was utility of care planning tools. I won't go into describing what those are. I think people have a general sense of what those constructs are. And I do want to mention a little bit about the exclusion criteria because the long and short of it is they actually excluded kids that were very medically fragile. Any children that, for example, had tracheostomies and home ventilation or a quote-unquote highly fragile medical status were excluded. Kids with recent ICU admissions, et cetera. So these were complex care kids, but not really maybe the most complex care children. And they looked at them, as I said, at 1 and 2 years. So there are 451 participants assessed for eligibility. 207 met the pre-established inclusion criteria. So that alone shows you that more than half of children were not actually deemed to be eligible. And of these, 139 participants completed baseline survey, and they had 117 participants completed the 12-month follow-up, 84%, and 78% the 24-month follow-up. So pretty good follow-up, actually, under the circumstances. But the findings, I think, are quite interesting. And I'm curious
Or what they don't show, right?
Yeah, for what they don't show and what they do show. I mean, it's a little bit of a head scratcher. So what they found was that at 12 months, the scores for utility of care planning tools were higher in the intervention group. So of the three main outcomes, only one of them with an odds ratio of 9.3. So very large effect at 1 year. But the other two outcomes were not different. And at 24 months, there were no differences in the outcomes between the two groups, pretty much in anything, in their primary or their secondary outcomes. There were no differences in ICU admissions, length of stay, emergency department visits, outpatient visits, primary care visits. And yet, despite all of that, and this is the part that Ali, maybe I misread it. So the healthcare costs were lower in the intervention group, $18,000 median Canadian dollar in the intervention and $37,000 in the control group.
I mean, I think it's hard. This study's, it's not a huge study.
It's not a huge study. So you're saying it might have been underpowered to see these differences?
Well, I know, because you're right. It seems like their costs were lower than the control group. I mean, they also said that overall, everybody's costs went down from baseline to follow up in both groups, including after the waitlist controls got the intervention. I mean, that's not randomized anymore to look at that, but
it's not randomized anymore. But I was just struggling with, they didn't notice any differences in any of these things, but the costs were lower. Isn't cost driven by ED visits, ICU visits, hospital?
Right. How did that happen? Yep.
What explains the lower cost?
Right. Or maybe the intensity of those things.
Well, and, it's interesting because I think to me was fascinating about this study is, it's effectively a negative study from the standpoint of outcomes that we would care about as clinicians. But strangely, from the perspective of a payer, it may very well be worth it. And, what's most of the time we've published and discussed studies where we found some benefit, but it's expensive, or we found some benefit, but no one's going to pay for it. Here's something where there was the only demonstrable, robust benefit that was seen was cost savings, presumably to the insurer, without other discernible benefits to the families. Mm-hmm. So what do you make of that? I mean, so is this something we should do even though it doesn't help families?
I don't know. I mean, I think that, the authors say this, and so does there's a nice editorial by Jay Barry and Chris Feutner that talks about, the evidence is mixed on these types of programs, which we do all the time, and they sound like they would be really good. And I think it depends on how you organize it and what's your objective. And I think the editorial talks about this, that, maybe these are still worth doing, like you're saying, for different reasons. Like maybe these aren't the thing to do if you want to decrease hospitalizations, but maybe that, things that families care about, like these processes of care, or these tools or whatever, are meaningful. I think we want these programs to do so many things, and they can't do all those things.
Yeah, or maybe the intervention, care coordination isn't intense enough. I mean, I don't know what would make it more intense, but
or it's diffuse, right? That it's hard to target all those outcomes with one type of intervention.
Yeah, right.
The thing I really admire that they did this, though, because I think that people do care coordination all the time without evaluating, does it actually work or not? And they, and people do this and they look pre and post, and, there's regression to the mean, and they say, oh, this worked. And they're doing a randomized trial to try to really look at that. So I appreciate that.
I agree. And we were honored to get it and happy to publish it. We publish research if it's well done, regardless of what the findings are. And, it's disappointing that this was a negative study, although the cost savings alone mean it should continue. And maybe there will be future evaluations, as you said, with other outcomes that can show benefits. All right. I want to thank you all again for joining us. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by the great Daniel Morrow at the JAMA Network. The audio team also includes Mary Lynn Ferkaluk, Audrey Foreman, Lisa Harden, Hannah Park, Shelley Steffens, and Dr. Linda Brubaker, Senior Editor, Multimedia. Thanks for listening. See you next month.